Mo, I just am realizing that I don't know how to introduce the Anapa team. Shall I introduce you and then you can introduce them?
You know what? I think it's best if you call on Miriam, and then Miriam will introduce herself and the rest of the team.
Okay.
Okay.
Yep.
So yeah, I'm just in the background. So basically, Miriam
Okay.
is more than capable of doing that. Thank you.
Okay. What's Miriam's title?
Hi, Ronji.
Hi.
Yeah, so it's a continuous grade improvement advisor, the title.
Oh, that's a great title. Okay.
It's really on the mark, isn't it, for this presentation?
Yes. Nice to see everybody joining. We're just waiting. We'll probably wait till 2 or 3 minutes after the hour before we start. Thank you, everyone. Good to see you. I think we still have about 5 more minutes, so we'll wait and see who's coming. Nice to see everybody joining. We'll still wait a couple more minutes, I think. I'm looking forward to this presentation. Maybe while we wait, just another minute or two, if you felt like putting your name and title in the chat, it might be interesting to get to know each other a little bit. All right, I think we should start. Welcome, everybody. It's nice to see everyone that's here, and also good to see that some of you sent your bots to so you can listen later. I'm Rondi. I'm the senior RMNCH advisor with Project Hope, and I'm a co-chair for the core RMNCH working group. And some time ago, we sent out a survey to all of you and asked for what kinds of topics you might be interested in. And both digital innovations and continuous quality improvement came up as a topic. And so we looked around to see who might be experts in that field. And we came up with a team actually within Project Hope that's been working quite extensively with supporting national CQI and digitalizing it. And if others have examples, I mean, we're very glad to hear during the Q&A of this project, but also we'd be glad to highlight the work that you've been doing as well. So with that, I'm going to turn this over to Miriam Window, who is in Malawi, and she's the continuous quality improvement advisor with that team, and she'll introduce her team, and then we'll proceed to their presentation, and then afterwards we'll have Q&A, and we'll be interested to hear from others on what they're doing. So over to you, Miriam.
All right. Thank you so much, Rondi. So like you've heard, I am Miriam Windo, Corridor Improvement Advisor for Project Hope here in Malawi in the Ananda Nyamata Patsogoro project. In short, is called ANAPA. I am with my two friends who are also going to introduce themselves. We are here basically to present on how the digitally enabled quality improvement practice is helping us here in Malawi, utilizing our case study. So I'll pass it over to my friend Wyson to introduce himself.
Wyson, you may, if I can't tell, but we're not hearing you. I think you're muted.
May you introduce yourself? Maybe he's having a Grinch. Over to you, Reston.
Thank you, Miriam. I'm Rested Matalo, informatics specialist here, Project Hope US Malawi. Thank you.
Right, so yeah, we also have Wyson Kandawile, the quality improvement officer in the very same project. So, like I said, we'll present to you the case study for Malawi. So, before we dive deep into the digitalized CQI, I'll just give an overview of what quality improvement is. Next. Next slide. All right, thanks. So, quality improvement, in short, QI, is a structured process that uses data to improve service delivery by addressing the gaps that exist between current practice and the desired standard. So, for example, we have the Sustainable Development Goal 3, Target 1, which aims at reducing maternal mortality to 70 deaths per 100,000 live births. But for Malawi as a country, we are at 225 per 100,000 live births, according to the Malawi Demographic Health Survey. So here you can see that our current level of practice as Malawi, we are at 225 deaths per 100,000 live births. But then the desired standard, which has been stipulated, is 70 per 100,000 live births. So when we are implementing CQI, it involves 4 steps. As you can see, the first one is assessment. So on assessment, basically, you're trying to understand the current level of quality by assessing standards of care or review of data. So like I said before, during the assessment, like for Malawi, that's where we know that now we are at 225 per 100,000 live birth in terms of maternal mortality. So after you've done your assessment, you are supposed to identify the gaps that are existing. So identifying gaps, you identify them between the current performance and the desired standard. So what it means is that in our case, we are supposed to determine why, as a country, we are at 225 per 100,000 lives instead of the 70 which has been prescribed. So once you identify these gaps, you are supposed to come up with changes or interventions that addresses the gaps. So you introduce the changes or solutions to address those gaps. So similarly, we know that postpartum hemorrhage is one of the leading cause of maternal deaths, and we have a new strategy to manage postpartum hemorrhage, which is the emotive, which basically is a comprehensive evidence-based strategy that is designed to effectively manage postpartum hemorrhage through early detection and timely intervention, significantly reducing maternal mortality. So in this case, you would take the emotive strategy as a change that you want to implement to support reduction of maternal mortality. So once that change has been implemented, then you are supposed to monitor. So you continuously monitor the effects of those changes to see if they've resulted in good outcomes or not, and then learning lessons from the whole process. So basically, you compare the outcome measures. In this case, you would compare the proportion of deaths due to BPH before emotive came into play to the proportions that you're having after the implementation of the emotive. So what is happening is that we are systematically improving the service quality by closing the gap that is existing between what is happening and what should be happening. Next slide. So yeah, CQI is a practical approach that helps teams regularly. One, to make data-informed small changes in order to achieve better outcomes. It also helps to identify the gaps that are existing in quality, reviewing how services are delivered, and continuously adjusting the approach in order to have good outcomes. So you'll see that CQI is not a one-time initiative or an external audit, but basically it is a way of working that helps the frontline workers, supervisors, and managers to use routine data and feedback to improve their service quality as well as client outcomes, solve some of the recurrent system problems that are existing, ensure that standards that are prescribed which are there are being met, and also are used for to make better decision. Next slide. Okay, so in CQI, there's a model that we use, which is the Plan, Do, Study, Act model. So this model provides a simple, structured approach for testing and implementing changes that can improve service delivery and outcomes. So each step in the cycle is builds learning into the improvement process, and the cycle also promotes learning through experimentation, allowing teams to build evidence for what works before expanding efforts more broadly. So on the circle that you're seeing, the first step is plan. So on plan, there are 4 things that are happening. First, you can conduct a CQI assessment for you to determine the gaps that are existing. So this CQI assessment, you can conduct it basically to assess against the standards that are already existing. Or you can also review the data that you're generating during the practice to see if you are having good outcomes or not. And then once you review the data or you conduct the assessment and you've identified the gaps, the next step is for you to conduct a root cause analysis. There are many methods that are used in conducting the root cause analysis, but some of them we have the fishbone analysis. Also, sometimes we use the 5 whys. And once you've done the root cause, basically you just want to understand the real underlying cause of the challenge or gap that you have. You bring out changes. So these changes are tailored towards the root causes that you've identified. So you develop an improvement plan that has changes identified to address the direct root cause that have been identified. So after that, as a team, you are supposed to decide what kind of data you want to collect for easy monitoring of the changes. So the data that you monitor on the changes, that one is the process measure, whereas the overall outcome, you decide to collect on the outcome measure. Once you are done with the planning, you go to the do step. So in the do step, basically, you just implement the changes that you had put in your improvement plan. You document what happens. For example, if you had an intervention that was to do with maybe conducting trainings, here you can put down maybe how many participants turned up for the training, and also you note the challenges or outcome. So you can also determine whether the participants came in time or late, or some of them missed the sessions, or maybe all the participants were able to come. So these are the things that you just note when you are implementing the changes. Once you are done on the do, you go to the next step, which is study. So on the study, basically, you review and analyze the results. You compare the numbers at the beginning of the intervention and the ones that are coming up after implementing the changes. So once you compare, you also evaluate to see if the results are bringing in good outcomes or not. And also at the same time, you gather feedback from the staff, specifically the ones that were implementing the interventions. After you are done on study, then you go to act. So on act, also there are three things happening. If an intervention worked, you adopt it. So you take it to be part of your system to be using on daily basis. Or maybe the intervention started working, but it needs a little change. So you modify it. That's when you adapt. So once you adapt an intervention or you tweak or change it a little bit, then it means you have to run it through the PDCA model again to see if it's going to bring the results that you want. If an intervention did not work, it did not bring any good results that you wanted, that one you abandon it. So on this step also, you are able to document the lessons that you've learned throughout the implementation of the PDCA model, and then you share with the team. So you will see that this approach allows the team to test solutions in a controlled way, minimizing risks and scaling up only what works. So within it, you see that we have a staff capacity building for them to easily utilize the PDCA model. So the staff need to be trained or mentored. And then we also have tools. In our case, the tools are digitalized for data correction, the one that we use whenever we are implementing our activities. And then we have the dashboards, basically to visualize the data that we are collecting when we are implementing the interventions. And then knowing that usually when we are implementing such activities, change doesn't happen instantly. Also, you need to consider change management, training the teams on change management, knowing that you would want the whole team to fully accept the approach that you're using. Next slide. Okay, so you also see that at the center of quality improvement is data. So basically, how we use this data, we start with collecting, and once you collect it, you are able to share with stakeholders. So these stakeholders can be those within that are involved in the data collection or to learn the PDCA model. You can also share it with external stakeholders during review meetings or any other platforms. So the data is then reviewed to identify a gap or spot a problem. I think, like I said, in the PDCA model, then the team agrees to implement smaller changes or solutions to address the problem identified to enhance program outcomes. The solutions are usually implemented on a smaller scale first to see if they work, and then once you see that the changes or the solutions have worked, that's when you can scale up to a larger group. And then you see that QI continues this cyclic review of data, making program improvements until the program change have become institutionalized or are then consistent. At this point, I'll hand over to my friend Reston to take us through the digitization process. Thanks, and over to you, Reston.
Thank you, Miriam.
Yeah. This slide shows how CQI has been digitalized in Malawi through 4 key building blocks. But importantly, this is also the sequence that we followed in implementation. So we start with stakeholder engagement, and this was critical to ensure that the digitization process reflects real service delivery needs. So we worked with the ministry and frontline workers to build consensus on standards and methodology, making sure that CQI tools align with how services are delivered. So for example, for RMNCH, this could include aligning tools maybe with a facility supervision checklist or ANC service quality assessments. The next, we also look at the system infrastructure. This is where we now digitize everything. So we are using the DHIS2 platform, which is open source and hosted on the government servers, ensuring national ownership. So within this system, we have digitized the CQI tools and processes, assessments, the improvement plan, the mentorship log, and also built integrated analytics and dashboards using the same DHIS2 as well as the Power BI analytics dashboards, and also supported access through gadgets and internet connectivity. So next, we also look at we also look at the implementation. So in implementation, we begin with the testing and field pilots to ensure that the tools and the workflows are practical and usable. So on implementation, we also operationalize the PDSA cycle within the system, including the quality improvement assessments, the indicator trend analysis, the root cause analysis, as well as the improvement plan, and also monitoring and actions. So an example would be that in RMNCH, a facility may identify low ANC visits, and you conduct a root cause analysis. You also implement a small change and track those improvements through the system. And once the system is now working and everything is operational, we then focus on capacity building. So this ensures that the users are not just entering data, but they are actually using it. So we also support the system administration at the ministry level, training on system use across the service delivery, monitoring, as well as the CQI modules. And continuous coaching and mentorship on the PDSA cycle also focuses on data use and improvement. So in this case, you might be able to use the system to identify service gaps, and you also use those dashboards to make decisions directly from that data. So we also emphasize on change management because moving from paper to digital requires behavior change. So overall, digitizing CQI is not just about the technology. It's about aligning people who are the stakeholders as well as users, and also the systems, which is in this case the DHIS and the Power BI, and the processes who are the which is the PDSA cycle. So this is done in order to create a continuous data-driven improvement system. Next slide. Now that we have seen how we digitize the CQI, let's also look at the key benefits of this approach. So first is there's data capture and automated analysis. Data is entered once using the tablets and also automatically processed within the system. This reduces manual work as well as the errors. And the second one is real-time visualization and for prompt action. With the dashboards that have been built using the DHIS and Power BI, users can immediately see trends and gaps. So in this case, let's say in RMNCH, a facility can quickly identify low facility deliveries, or let's say missed postnatal visits, and you might be able to take action immediately after looking at the dashboards that we have built and you're analyzing the data. So this shifts decision making from delayed to real time. And we also look at the cost effectiveness. So digitization reduces the paper-based processes, the duplicate systems, and also time spent on manual reporting is also reduced. And leveraging the existing national systems, which means that you are achieving better outcomes without significantly increasing resources. So the other one is integration. So CQI is embedded within the existing systems, not a separate platform or a separate component. So this allows data to be linked across the community services, facility services, as well as the outcome indicators so that teams can be able to see the full picture of service delivery. And finally, enhanced accountability. Because data is visible and updated in real time, frontline workers can be able to track their own performance, supervisors can be able to provide targeted support, as well as managers can also monitor progress across facilities. So overall, technology-enabled CQI transforms programs from retrospective reporting to continuous data-driven improvement. And this is exactly that maybe RMNCH programs can also be able to adopt by digitizing their tools to integrate them into the system and actively using data to improve outcomes. Thank you, and over to you, Wyson.
All right, thank you, Weston and Miriam, and also thank you, Rondi. So apologies, I had difficulties with my gadget. It just got muted during the introduction, so I couldn't hear anything. So I will start by introducing myself. I'm Wyson Kandawie, and I work as QI officer with Project Hope in Malawi. So the same office as Miriam. Yeah, so, and I'm also honored actually to be part of the presenters here. So, colleagues, my responsibility here is just to highlight some successes, lessons, and challenges. So as you can see from this slide, this is just one of many examples in which digitized CQI improved the system usage. So you see that before we introduced CQI in OVC services, CPIMS use was extremely low among both frontliners and also managers at ministry, despite having most of the necessary system tools and infrastructures in place. So users actually continue to rely on manual and fragmented data processes, which limited data use and efficiency. Through the CQI process, we conducted root cause analysis and found that one of the main barriers was limited practical knowledge and confidence in using the system. So in response, you can see that between May and September 2025, we implemented tailor-made CQI intervention focusing on hands-on CPIMS coaching for frontline workers, even the people from the ministry, strengthening their data use for decision-making, not just the data entry for the system. So a simple dashboard was developed to track volume, timeliness, and user-level performance. So this actually enabled both users and managers to monitor progress in real time and take swift action. The result was immediate, as you can see from the graph. The improvement in system usage, which currently has been sustained and continues to improve actually over time. So you can see that this rapid improvement occurred across 9 districts, and without actually digitized processes, this wouldn't have been possible given the cost and the resources that are available if you consider the traditional way of doing CQI. Next slide, please. Thank you. So this slide basically shows the CQI linked outcome indicators, which is the improvement in viral load suppression amongst OVC, and this is our core business actually here. So you see that we implement CQI at both individual as well as facility level. So on the left, you see the viral load suppression rate for selected facilities in about 5 districts. So one of the interventions that we had is establishment of facility coordination teams. So what you see, those that are in blue, is actually viral road suppression rates before the introduction of the coordination committees at those facilities. And what you see in orange, actually the viral suppression afterwards. So in general, you see that there is a effect in terms of the increase in viral load suppression rate after implementing that, which was aided by the system. So on the right is actually the individual trend of viral load test results for one of the child who had high viral load. So this was done by frontline worker following the lessons on PDSA. So for his own actually improvement action. So you see that through the root cause analysis, the individual had specific improvement plans which helped the child to suppress up to the level that it is no longer detected, and through CQI process, it has remained like that. So you see that this iterative digital CQI cycles proof is a proof actually on how slight changes seamlessly translate into data data into measurable health outcomes. Next slide. Yeah, so we also had several key lessons. So we learned that continuous mentorship and coaching proved far more effective than just one-time training. Yeah, so also developing simple user-friendly dashboards are also very, very critical in enabling data use at all levels, whether the ministry, district, and even communities. Area and sustained leadership engagement ensured alignment and ownership and actually continue to support from the government. And more importantly, aligning digitized CQI with national system enhance scalability. And actually, we hope that this is going to be pivotal in terms of ensuring sustainability moving forward. Overall, the success of this approach comes from the combination of three elements: technology, people, and the processes, as Miriam and Reston have alluded to already. So yeah, digitized CQI brings these elements together to drive the measurable improvements in any service that we can have CQI digitized. Next slide. Thank you. Yeah, it was not an easy ride. We also had challenges. I would say that there is limited connectivity and infrastructure in some districts in Malawi, which affects real-time data capture and especially access to dashboards. So this required us to adopt flexible approaches, including using the offline abilities of data entry. And actually, for those that don't have the Power BI in their Microsoft environment, like government users, we are using the web-based deployment of the dashboard so that they are able to access the dashboard for their decision making. So initially, we had resistance from the stakeholders, particularly from the users who were used to the traditional paper-based system. So transitioning to digital required actually both change management approach and continuous support, as Miriam alluded to in her initial section. So we also noted that there were variations in digital literacy among frontline staff. Some users needed more intensive hands-on coaching to build confidence in using the system. And this, to some extent, affected the data quality that was entered into the system. So to address these challenges, we strengthened mentorship, simplified tools, and ensured continuous engagement with the users and their mentors. Next slide. Thank you. So here, basing on our experiences implementing the digital CQI, here are some of the practical considerations for RMNCH program. So first, we need to secure, you need to secure the buy-in early from the leadership and keep them engaged throughout, because digitizing CQI is not just a technical activity, it requires a strong leadership support. Without them, it is not possible. So from beginning, leadership needs to endorse the approach, align it with national priorities, and remain engaged during the implementation. Second, we need to invest in ongoing mentorship, not just once-off training. So one of the biggest lessons is actually that the training alone is not enough to really push the agenda. So users need to continuously supported to build confidence in terms of using the system, interpretation of the data correctly, and applying the PDSSA in their daily work. It is also important to align CQI tools within national health information systems. It is important not to create a parallel structure or system. So CQI tools should be embedded within the existing platforms like DHIS2, like Reston mentioned, which is also connected to many national indicator platforms. And finally, designing the dashboards the dashboard should be designed in a simple and actionable manner, and also focusing on priority indicators. So dashboards should not overwhelm the users, as we experienced. Most had difficulty to use them when they were heavy. So they should clearly highlight key performance indicators, priority gaps, and areas that need actions. Next slide. Yeah, so there you are seeing a group photo which was taken during the initial engagement with ministry. That is leadership from the ministry. We had people from the district councils and here and there people in the from the frontline workforce. Yeah, so this is where we set the agenda, engage them in terms of what standards should be there and the methodology that should be followed in this digitized CQI process. Next. Yeah, so that slide is actually showing to, in the left side, you see pictures of coaching sessions. The top left is coaching district staff members who are mentors of the frontline work. Example is the left bottom picture where you're seeing the Project Hope staff mentoring one-on-one the CPW, who is a front line worker. So on the right-hand side, you see a snapshot, a screenshot of the DHIS2, CPIMS2, where you're seeing the digitized forms. The module quality improvement has, for example, CQI assessment form, PDSA digital 2, and CQI mentorship log. Next. Yeah, that one is a sample, a screenshot of a dashboard, the quality improvement dashboard, which you can actually customize, and you can filter based on the year, fiscal quarter, organization, district, TA, and even the facilities, whether they're government-led or from the community. So you can filter it to your liking, and you can see the summary of the facilities indicated there. Yeah, and their scores. So they are also color-coded to help real-time kind of understanding and getting the meaning of the dashboard. So each score is actually color-coded. Next. All right, so basically, this is a feedback from Madam Trofina Libani, who is a Principal Social Welfare Officer, but also a National Coordinator for Case Management in the Ministry of Gender and Children and Welfare. So she said, and I read, the Ministry of Gender values coaching and mentorship on CPIMS and CQI. These initiatives have significantly strengthened our staff capacity to use data for decision-making, improve coordination at facility level, and enhance delivery of social services to vulnerable children. Through hands-on mentorship, government-led facilities have become more confident in identifying service delivery gaps, developing practical improvement plans, and tracking progress using the CPIMS. This approach is helping us institutionalize a culture of accountability and evidence-based programming, ensuring that every child receives timely and quality protection and care services. So in closing, what we've shared today is not just about digitizing tools, but about strengthening the way quality improvement is implemented in practice. By combining structured CQI processes with digital systems, teams are better equipped to identify gaps, act on them, and track progress over time. So in the Malawi experience, the one that we have here shows that when the approach is aligned with government system and supported through mentorship, it can lead to more consistent data-informed service delivery. We hope this provides a practical example that can be adapted to different RMCH contexts, and we look forward to hearing actually your reflection and experiences about this presentation. So thank you so much, and I hand over to the chair for this meeting. Thank you, and over.
Thank you so much. This has really been a very great presentation. I mean, I knew something about what was going on, but this has really helped me to understand more. And I see that we already have questions in the chat. So really nice, Miriam and Renton and Wyson. I think I'll just jump to the questions. We've got a couple that are in the chat. Joy is saying, amazing work being done by the Malawi team. Could the team please share more information on the role and responsibilities of the facility coordination teams? Is one of you up to responding to that?
Yeah, I can start that. My colleagues will chip in where necessary. Yeah, so basically, because of the nature of the activity that we are doing here is to actually enhance virus suppression amongst the children living with HIV and on ART. So what we've discovered is that we're still facing a lot of challenges, which are also social, economic in nature, from where they come from, their households. So these kids they have different needs in order for them to really take drugs based on the guidelines in terms of adherence. So some of the needs can only be addressed through the what is already existing in their setup. So the coordination team is actually comprised of stakeholders who are in different sectors like agriculture, nutrition, the clinics sector, and and many others. So sometimes this coordination team is like a resource map platform where when there is a kid who is not adherent on drugs because they lack food in their household, then one of the coordination member actually may have that happening in the community, but only that they are not prioritizing them. So that is the main role of the coordination committees in the facilities. So that has helped quite a lot in terms of providing the necessary social economic support from different sectors, but also it has also helped in trying to speed up the referral pathways for different social services that these kids may require in order to suppress. So basically, in a nutshell, that's their main role.
Thank you. Does anyone else want to add to that? All right, let's move on to. Oh, go ahead, please.
Okay, I wanted to say that Wyson has covered it all. Maybe just to say that in the coordination committee, there's a child protection worker who is directly linked with the child. So basically, whatever issues they identify on that child, that's when she or he refers to the coordination committee members to see if an issue is to do with health. Then the health care workers will come in to support the child. If it's something to do with food, they would link with agricultural extension workers or maybe community development personnel to support that child in order for them to suppress if they have a high thyroid. Thanks, and over.
Thank you. And I guess maybe one thing I'm hearing is that it's not all digital. The digitalization helps us to identify what the problems are and whether or not things are changing. It helps us to follow whether we're having impact, but still there's a need for people-to-people contact and to figure out how to problem solve once the problems are identified. So there's another question here in the chat from Adimasi Teshomi Mirhet. Says, thank you for sharing the wonderful initiatives and lessons. Just for clarification, does the service delivery digitalization, does patient data entered in real time, or do you use data from registers at the facility?
Yeah, okay. Miriam, you want to start?
Okay, yeah, I can start. So basically, in the child protection management system, they have what we call case management red booklets. So these are physical documents whereby they use them to document when they're assessing the child, maybe coming up with a plan on how to support that child whenever they identify issues. So the data that is entered in that red booklet is the one that is transferred into the digital tool, which is basically in their tablets. So sometimes when they go to the household and they are having that engagement with a household directory, they can also enter directly data into the digital tool. In case of the challenges that were already alluded to say that sometimes we have connectivity challenges, sometimes we have issues to do with blackouts here in Malawi, they can fill that red booklet to later on enter the data in that digital tool. But so to say also that in this system, they don't really have like registers, but each child has their own red booklet where information is entered.
Yeah, just to add, we are at a transition phase where we are moving as government from the paper-based into the system. And I think the system will be launched nationally very soon. And actually, the requests have been coming from the government to actually comprehensively digitize the whole process so that we move away from the paper-based, which is also a strategic priority of government moving in that direction. So I think Restin can add more on that one, but it is just a transition that now we're able to use the red booklet because we are moving. Very soon we'll fully transition into digital where people will actually go with the tablet and offer the services, the whole cycle, the whole process on the digital platform.
Reston, do you want to add something?
Yeah, not at the moment. I think Wyson has already covered what I wanted to say. Thank you.
So I guess I have a question along that line. Is it I guess these are maybe not healthcare providers, but in a situation where you're providing healthcare, would it be the healthcare provider that's entering data directly, or would there be a separate data person at the health facility that is reading what the healthcare provider has written?
It's interconnected. So basically, the CPWs who are child protection workers, they are the ones like in what we are doing now. They are the ones who are actually collecting data like from the point of generation at household when they are doing the OVC services. So where they refer for services for other social services like health services or nutrition services, data will actually be captured there. But in our system, it will be updated that this ABCD got this help as a service from this section or from this section. So yeah, it's interconnected, but data is collected where the service is being offered and actually updated in the system by the frontline workers. Yes, Reston?
Yes, and also just maybe to add on that, the only person who is entering data into the system is the one who is managing the case files for that children. So that person is the one who is now called the child protection worker. So in coordination, the coordination between the child protection worker, the health facility, and also other stakeholders, they are able to provide services to that child. But then the CPW or the child protection worker is the one who is now recording all the information and also entering to the system so that people can also be able to see. Thank you.
Excellent, thank you. are there other questions? I invite other people to ask any questions that you have, or if you have experience with CQI, to share with us what you've done with CQI or with digitalization. Feel free to raise your hand or write it in the chat.
Just a quick question, since we're talking about the data entry and like different people entering and accessing data, has there been an issue around data security and privacy? And how was that managed with that multi-people access and entering data in the system?
Reston?
Yeah, thank you for that question. So when it comes to data management and also privacy, like I said, that we have these child protection workers who are at a facility or they are at a traditional authority that is below a district, and then we are looking at the whole country as Malawi. So we make sure that as we are organizing or as we are assigning the facilities to these child protection workers, each and every CPW has got rights to update or enter data in that specific facility only. In other words, I can say that there's a role-based access control whereby there's a limit of who can do this and who can also be able to do this. So for the child protection workers, they are able to enter data. They can also be able to see the data that has been entered by them only. Now we look at the district level. So for the district level, they can be able to see the overall data in their own district, or we can say in their own region. And then as the ministry now, the government of Malawi, they can now be able to oversee the data at the country level. So in other words, that is kind of the idea in terms of data protection and data security. And also in terms of data security, as we are using the DHIS tool, in terms of security, it's more secure, it's open source. People have been able to test it to make sure that it also addresses issues to do with privacy. So as data is being transmitted from the mobile, it's also encrypted as it is going to the server. Thank you.
Yeah, we all think about that, and I mean, I think it's tricky in general, but it's good to know that you've really put some thought into it. Any other questions or sharing of experiences? Looks like we have something from Elizabeth. Do you want to share a little bit?
Hi, Randy, and good morning, or no, good afternoon from Ghana. And thanks to Malawi for the presentation. I just want to add my voice to the digitized CQI system. So Project Hope in Ghana has also digitized our CQI system. And I always look at the thematic areas within which we are implementing. So maternal health, newborn, child health, nutrition, malaria. So all the quality things that we want to see when we enter into a facility are captured in the digitized system. And we actually developed this based on the government's supportive supervision tool. So we didn't want a situation where our system will look so different from what the government is doing. So we adopted that and then added our own input. So when we go into a facility, that is what we use. And we are able to access it. It's actually on DHIS2, and we are able to use our phones, and where we are supposed to provide tablets for the activities to be done, we are able to do that. We have a dashboard that at the end of the day is able to give us like live data of whatever is going on in a certain facility. So we are able to identify the gaps wherever you are. Once you have access to the DHIS2, you are able to see what is happening, you know the gaps, and you are able to support the facilities. So, I mean, it helps you do a deeper dive into which facility is having challenges, and it's very good. Yeah, so this is what I wanted to put across. Thank you.
Thank you, Elizabeth. I really appreciate you sharing that. Who enters the data in the situation in Ghana? Who is it that enters the data?
The service provider. So let's say if I go on monitoring, or the service provider is trying to strengthen quality within the facility, they are able to assess the situation and then they do the entries. So a facility is able to use the system, and then as Project Hope staff, when we go on round, we are also able to use the system. So once the person is oriented on how to use it, they are able to use it.
And so do all the facility staff have access to some kind of tablet that they then upload data? How does that work?
Our facilities have access to that.
Yeah, that's interesting. And is there anyone, thank you for sharing that. Is there anyone else that has experience with digitalizing CQI that feels like sharing? Or has questions for Elizabeth or the Malawi team? I guess I wonder about sustainability, both Elizabeth and the Malawi team. I do hear you saying that the government wants it and they want to go less paper and more digitalized, but how much project support is needed to keep it sustaining? If we lost funds, do you think it's something that the government could maintain?
Hey, Rondi.
Please.
Okay, so yeah, so in terms of sustainability, what we've done here in Malawi, I think throughout the presentation, it was said that the government stakeholders were on board from the start. So during the capacity building activities, at first we started at national level to make sure that the national team is well conversant with the system, and they can be able to support the stakeholders in the district as well as facility level. So what we've seen is that when we were scaling down this implementation, the government staff are the ones who are taking lead, supporting the district or facility teams on how they could navigate through the CQI tools and then other tools that were digitized in the DHIS2 platform. As such, we see that moving forward, as this project goes to an end, they will be able to take over and continue the digitized processes, since we've tried our best to support them in building all those infrastructures from the national to the district level, even the tablets that we're talking about, they have, and also it was also presented, we've made sure that even the data entry is not just in real time. They can even do it offline in case such kind of resources might not be available as always. Over to you, Resty.
Thank you.
Thank you, Miriam. And I just wanted to add that in terms of sustainability, we already installed the DHIS2, and we're also planning to install the website where we are hosting the Power BI dashboard in the government. It's hosted in the government, but now we are also planning to move all those services to be installed at the Malawi government data center, which means that there will be no cost in terms of for them to have the system up and running. And not only that, in terms of the technical capacity of the Ministry of Gender ICT, we are making sure that they are well trained, they have the capacity so that they can be able to manage all the requests and troubleshoot all the issues that come from the either from the CBWs or from the users of the system, so that as we are there, we just give them support. When we are not there, they can also be able to use the system, and or it should be in operation as if we are still there and providing support. Thank you.
Thank you, Reston. Wyson?
Yes, thank you, Randy. Yeah, of course, I can't speak for government, but as a Malawian and someone who is following what is happening, so basically in Malawi we have the commitment is there by government in the both long-term strategy as well as short-term strategic plan. Digitization is one of the areas that have highest priority for the government. So just like Christian has mentioned, they have already developed. They have the infrastructure, like the e-government and everything that is digital, regardless of the sector. They are going to be housed there. For example, in the Ministry of Gender, actually, they have about eight, I would say eight systems. And what Project Hope is supporting is just the three that are functional out of the eight. So the movement and the commitment is already there, even at that level of planning by the government. So we hope with the capacity building, with the infrastructure, the enhancement that we've done to the system, it is going to be sustainable in the foreseeable future.
Great. Thank you. And that seems like a good note to end on. I see we're at time. Thank you very much to the Malawi presenters and for all of you that came and for those of you that shared and engaged. I've really found this to be a very interesting session. And feel free to reach out if you have more questions. And I will be sharing the information. So have a good rest of your day.
Thank you so much, Rhonda and the colleagues. Bye-bye.
Thank you, Ron, and all.
Thank you and bye-bye.
Bye-bye, everyone.
Bye, Rondi.
Bye-bye.